So today we're going to talk about gunshot wounds to the external genitalia. And the objectives for this talk are to review the literature on ballistics and to apply this information to gunshot wound injuries to the penis, urethra, and the scrotum. This is a headline from the Vancouver Sun in the last week. Man killed in a hail of bullets in Vancouver neighborhood. This is actually down in Fairview Slopes, a couple blocks away from the Vancouver General Hospital. So it's quite possible that we could get a penetrating gunshot wound injury to the GU system. In terms of gun ownership in Canada, a small arms survey performed a few years ago in 2007 found that Canada actually owns about 30 guns per 100 residents. We rank 13th out of 187 countries for gun ownership. About 5% of Canadian population has valid firearm license. And obviously at the top there, United States, not surprisingly.
Does that include long guns?
That's both, like long guns. That's like the firearm registry that, as well as like the small like handguns. I guess they surveyed the population with questionnaires.
All the hillbillies in Alberta.
Yeah, so you can have multiple firearms per person, which is why
And the
it's 30.
swamp rats in Ontario.
Yeah, definitely. So, in terms of the incidence of GU trauma, a lot of our data is actually based on the Americans, and more specifically based on theaters of war. But in general, trauma to the GU system has been seen in anywhere from 2 to 10% of hospital admissions. About a third to two-thirds of these admissions have involved the external genitalia. And obviously men have been found to be more prone due to exposure to violence, aggressive sports, and MVAs. When we classify gunshot wounds, there's a number of factors to take into account. So the kinetic energy of the weapon is one of the factors that has been focused on in the past, but other factors also include the bullet type, the stability of the bullet in flight, as well as the expansion and fragmentation of the bullet, and secondary impacts within the tissue, which can cause additional tracts. The bullet velocity we classify as either low or high, and the cutoff for this is 1,100 feet per second. The schematic on the right-hand side over here, we have a shell which consists of a bullet and primer behind the bullet. So we can describe the velocity and the energy that's given to the bullet through the simple physics law, E is equal to 1/2 mv squared. The energy that's imparted to the tissue, therefore, depends on both mass as well as velocity of the bullet. And just out of interest, on the bottom here we have a number of bullets. The handgun bullets would sit way to the left-hand side over here, probably down in this range, if you're to have the bullets on this scale. These are all rifle bullets, sir. In terms of handgun bullet characteristics, they do range in terms of the weight, ranging from, on this chart, 40 to 100 grains, but also range in terms of the muzzle velocity. And you can see here that the muzzle velocity typically ranges in the 1,000 range. Contrast this to the rifle bullets, which also range in weight, but for their velocity in the second circle, the second column over there, velocity is closer to the 3,000 range, and this imparts a much larger energy at the muzzle to the rifle bullets. Other considerations include bullet yaw and tumble. On the top left here, that's a cross-section of a rifle barrel. You see lands and grooves in the barrel, so as a bullet spins out through the barrel, it's given a rotational energy. This gives it additional stability as it makes its way towards a target. And this is seen in the bottom left diagram with the yaw, the yaw increased as it leaves the barrel and decreased as it strikes the target. The yaw is then transferred into a tumble within the tissue, and the tumbling of the bullet exposes additional cross area of the bullet and causes additional damage to the tissue. Bullet design is also very important. The type of missile can be characterized into a full metal jacket, which means that there's a copper cladding around the soft lead core, versus total metal jacket, which has copper cladding around the bullet as well as the back, versus hollow point or soft point and less known rounds such as PTFE, exploding rounds, armor-piercing rounds. And as example, I have at the bottom right the number of the hollow tip bullets, which not explode on impact, but compress and enlarge on impact, giving a larger area to damaged tissue. The bottom left-hand picture shows a black talon bullet, which was notoriously known as a cop killer, which expands upon impact, exposing 6 claw-like talons, as you can see on the bottom left-hand side, further shredding tissue as it passes through. Fragmentation of bullets seems to depend on the range as well as the velocity of the bullet. As we compare the top 2 rows to the top, or to the bottom two rows, we see that at close range, high velocity, same bullet can fragment into many pieces, and these can cause secondary paths to the tissue, whereas at low range they might be more likely to stay intact. So in summary of this, the mechanism of damage to tissue includes direct cutting of the tissue, which depends on the size of the bullet, fragmentation, tumble, bullet expansion, as well as temporary cavity, which is the energy transfer imparted by shock wave as a bullet passes through the tissue. The temporary cavity then in turn depends on viscoelasticity of the tissues, where inelastic structures such as the spleen and liver, instead of stretching due to the force, are ripped and damaged instead. Shock waves were previously thought to be important in terms of damage, and these are waves that precede the bullet and were thought to reach pressures up to 200 ATMs, but for short periods of time. This is thought to be more impressive in terms of tissue that are sensitive to concussion, such as brain matter. Represented diagrammatically, jacketed bullet, as it passes through the tissue, we have the main line through there, which is the permanent cavity. This is the damage that's caused by the bullet directly, and in the shaded area around it, the temporary cavity, which is caused by the shock wave as it passes through. Take in contrast a non-jacketed bullet, which has a much wider permanent cavity due to fragmentation, expansion at the tissue, and lesser so effect on the temporary cavity. In extreme, a bullet can fragment, causing additional tracks, and this is an M16 bullet, which has been known to be pretty notorious for fragmenting upon impact. And you can see with the red arrows there that secondary tracks can be created throughout the tissue, even though there's one single entry point of the bullet into the body. So Santucci and Chang went back and reviewed all the ballistics literature and published in the Journal of Urology in 2004. There was approximately 70 articles and book chapters on this topic. They found a number of myths being propagated in terms of wound ballistics. Number one, they found that there was overemphasis of wounding potential on the velocity of the bullet, and this isn't always true. Number two, they found that wide excision is mandatory for high velocity rounds. This isn't also always true. Thirdly, high velocity bullets always yaw in the tissue. Again, not true. And finally, bullets are sterile after shooting, also a false assumption. So in regards to the velocity of the bullet and damage, they made observations in terms of the Vietnam experience and AK-47 injuries, and there was experience demonstrating that a number of these bullets passed straight through their victims despite being high velocity rounds, where you would expect a lot of damage and a lot of damage to the surrounding tissue. They found a straightforward tract with minimal damage that often healed spontaneously without much intervention. They also looked at case reports where high velocity gunshot wounds were mistaken for low velocity rounds and treated as such, and there was no difference in the outcome. And finally, that gelatin is an imperfect model for human tissue, and that doesn't factor in the skin, which can slow down the bullet. This group, led by Dr. Liu, looked at the rates and incidence of infection when bullets are fired into dog muscle, and they found that consistently at 6, 12, and 24 hours, the wounds were infected. So in conclusion from the Santucci and Chang group, they thought that suggestions for debridement should disregard previous suggestions in terms of debriding based on color consistency, contractility, and circulation, because these can often be erroneous and misleading in the early periods. They suggested debride the non-attached tissues and then come back in a couple of days for re-examination. Over-debridement causes unnecessary harm and was not found to be necessary in the current era. They suggested to treat the wound and not the weapon. Shotgun injuries deserve a special mention separate from what we've already discussed. Shotgun shells can contain up to a few hundred shots within a cartridge. This causes a low velocity but large blast effect, and this can be devastating. Look at the pattern plates down here, and you can see how wide the injury is from a shotgun blast. And on the right-hand side, a retrograde urethrogram demonstrating shot. Imagine trying to excise that tissue and clean all the shot pellets out of that patient. So Tegert went back and looked at patients in Detroit. They had 140 firearm injuries between 1990 and 96. 10 of these were shotgun injuries. 9 of these were male. 1 was female. And as you can see here, there was a lot of associated injury to bowel, rectum, colon, vascular structures. Not only that, but there was also injury to, bladder, as well as penis, as well as gonads concurrently. They treated all their patients operatively and found that of all these patients, 2 required urethroplasties, and 1 actually required a Mitrofanoff for diversion. Erectile dysfunction was present in 50% of their patients. So switching gears a little bit, say you have a patient that rolls into the emerge and you've been asked for an assessment in regards to GU trauma. What is your initial assessment? Well, assessment is based on ATLS guidelines, so stabilize first. ABCs, C-spine precautions, a secondary survey, then proceed on to history. When I elicit weapon type, caliber of bullet, voiding history, presence or absence of gross hematuria. A physical examination, which includes but is not limited to GU exam, neural exam, and digital rectal examination, both for GU injury as well as concurrent bowel injury. And you want to try to assess for entry and exit wounds. The radiology workup includes a retrograde urethrogram and your focus should be to stabilize severe injuries first. So we divide the injuries into penile injuries, which can include urethral injuries, and also scrotal injuries, which can include testicular injuries. And I'd like to talk about penile injuries first. So this is fairly recent data. Paquette and colleagues looked at the genital urinary injuries in the Iraq War. This is Operation Iraqi Freedom, which commenced in 2003. They looked at 2,700 patients. 2.9% of them had GU injuries, and then they further subclassified these into kidney, ureter, bladder, urethra, scrotum, testicular, and penis injuries, as shown on this table. The penile injuries were seen to be about 6% of the GU injuries in total. Of the civilian data, Kunkel and his group had the largest review. Approximately 63% of these patients were identified, and they found that there was a high association of penile injuries with other injuries. Down at the table at the bottom right here, scrotal and testicular injuries in 56% of their patients, thigh injuries in 75% of their patients, and other injuries including intra-abdominal, vascular, and nerve injuries in approximately 10%. They also reviewed the previous literature in terms of gunshot wounds to the penis. Most of these studies are small in numbers. They date back to approximately 1992. Overall, the urethral injury rate associated with the penile injury was approximately 15 to 30%, so a fairly high rate. In terms of the workup, a number of radiologic modalities can be employed. Ultrasound can be used to query for a scrotal injury, MR or CT when you suspect injury in adjacent tissues. Cavernoscopy is rarely used. And I'm not sure how many of the radiologists or the urologists are used to this. So it was thought to lead to high rates of misinterpretation, and therefore seldomly used. The retrograde urethrogram is pretty standard. And interestingly, Kunkel noted that they didn't do a retrograde urethrogram in approximately 21% of their patients. These patients had no missed injuries, but these injuries were superficial in nature. Similarly, Goldman didn't perform rugs in their patients with superficial wounds and had similar findings. So here we go. Operative management. Most of the literature describes a subcoronal degloving incision, although there is description of a penile scrotal incision. The subcoronal incision is supposedly able to give you a better exposure, therefore facilitating the exploration. Vascular control is through a tourniquet at the base. You can see the white tourniquet at the bottom. Primary reapproximation of the injury is performed intraoperatively. Artificial erections are used to assess for any deviation in curvature as well as any remaining defects in the repair. Plication sutures are placed as needed, and the wound is rinsed with antibiotic solution post-repair. The skin can be closed primarily. Here's another example. So an associated thigh wound with a corporal injury that was identified in the middle picture intraoperatively and repaired with seemingly good results. In terms of outcomes, most of the series show that erectile dysfunction as an outcome has been pretty good. Kunkel, who had the 63 patients, had follow-up in about half of their patients. Of these patients, 6% had mild curvature, 15% reported ED, and one patient unfortunately had delayed foreskin necrosis. In Tegert's series, 50% of their patients had ED. However, we have to consider this is in the setting of shotgun injuries and quite a different injury than a straightforward penetrating bullet. So Klein and their group looked at about 40 patients and had similar results to Kunkel. About 22% of their patients had ED. The mechanism, they don't know, but thought to be damage to the veno-occlusive mechanisms, or damage to the arterial inflow, or damage to the neural innervation of the penis. Switching gears again, moving on to urethral injury. There weren't any large series that I identified in terms of urethral injury, but McAnich, who's very involved with external genital trauma, had a series in terms of the Civil War down in the States. They reviewed about 1,500 cases of GU trauma, 7% with urethral injury, the majority of these with the mini ball. So the mini ball is somewhat similar to the hollow point bullet, but it's fired through the musket.
Code Blue, Jim Pattison Pavilion, Tower 5B. Code Blue, Jim Pattison Pavilion, Tower 5B.
In terms of their outcomes, there was a fairly high mortality rate. About one-fifth of their patients passed away. And of these patients that survived, a high complication rate was seen. 35% stricture, 47% fistula, 20% incontinence, and 12% impotence. Full recovery was only seen in 20% of their patients. So their management at that time was to pass a catheter across at the assessment of injury, and if that didn't work, to attempt to filiform. Persistent retention was treated with a suprapubic puncture, either suprapubic or through the rectum, actually, which I don't know about you guys, but I've never seen. The more modern literature, so going back to Paquette's data, in the Gulf War, Operation Iraqi Freedom, there's approximately 17% urethral injury of all the genital urinary trauma. And this was similar to the Vietnam and World War II rates. The workup of urethral injury includes a retrograde urethrogram, and indications are blood at the meatus, gross hematuria, or suspicion of trauma, inability to void. On the left, we have a normal rug. On the right, not so normal. Other tests that can be performed: a flexible cystoscopy intraoperatively, and or installation of saline into either the urethra or the corporal bodies, but this is only suggested if retrograde urethrogram is not available. Classification schemes have been suggested by Colapinto. The AAST, which bases on contusion stretch as well as partial versus complete disruption, and whether that's less or greater than 2 centimeters. But the EAU has also suggested their own classification scheme and tried to classify them so that the management can be broken down by the type as seen down below. In terms of the management, it's actually pretty straightforward. If you have a anterior urethral injury, whether it's complete disruption or partial disruption, if it's a penetrating injury, you're going to go there and explore, as seen in the circled boxes. Similarly, for posterior urethral injury, whether you have complete or partial injury, if you have a penetrating injury, you're going to go in and explore, as seen on that flow chart. So the technique for repair has been described as mobilizing the ends of the urethra, spatulating, creating a watertight, tension-free end-to-end anastomosis over a catheter, and then attempting to provide coverage to minimize complications such as fistula formation and leaks. It's thought that the debridement should be minimized. And overall, the outcome rate from this has been quite good, about 15% stricture rate. Of note, if there's extensive damage, delayed repair may be required, utilizing a two-stage repair. Antibiotics should be administered postoperatively, and a cystogram should be performed a few weeks afterwards to assess for a leak. The catheter can be removed if there is no leak present. So I wanted to talk more about the outcomes of urethral repair. And Hussman had what seemed to be the most relevant series. They looked at 17 patients at UT Southwestern with a 20-month follow-up. These patients had partial transection secondary to a gunshot wound, and they divide these into stenting with a catheter versus primary repair with suturing. What they found was 78% of these patients had stricture when treated with just the indwelling Foley catheter versus 12% stricture rate when they were primarily repaired. Their recommendations are quite obvious. In regards to the posterior urethra, there was a series by Tausch looking at patients that presented to the Brooke Army base, and they retrospectively looked at 19 patients. Of these 19 patients, 15 of them had delayed reconstruction. 2 had immediate primary repair, and it sounded like these patients were unstable from their descriptions. And 2 had complete prostatectomies due to injury to the prostate, mid-prostate or urethral stretch within the prostate. They found that delayed repair had a good outcome, with approximately, again, 15% of their patients having strictures, and the 2 strictures that did occur, they treated successfully with urethroplasty, so good outcomes overall. Immediate repair had no issues. They had normal flow rates afterwards, and the prostatectomy, one with loss of follow-up, and the other gentleman unfortunately had urinary incontinence. So their conclusions were that posterior urethral injuries are often associated with other injuries, and you should stabilize the patient first. But for patients that require exploration, you can perform an abdominal midline incision, which facilitates good exposure to the injury. And moving on to scrotal injury now. Again, the algorithm is pretty straightforward. Penetrating scrotal trauma, open repair. So, interestingly though, in the consensus report, there has been non-operative management reported. Workup involves imaging, although imaging is not necessarily required. Ultrasound has been shown in the past to have specificity 75%, sensitivity 64%, and this is based on a study by Learch in 1995. So on the left-hand side, we have an ultrasound of a testicle with a hematocele, and on the right-hand side, a intraparenchymal defect suggesting rupture This is the data from Lirch. Their total number of patients was 19, and of these, 11 of them had no testicular rupture. 6 other patients had testicular rupture suspected on ultrasound and underwent surgical exploration. 4 of those patients actually had rupture. 1 of them had tunica albuginea violation without actual parenchymal exuding from the testicle itself. And 1 patient was found to be a overdiagnosis, which they blamed on a junior radiology resident. So in terms of findings with a gunshot wound, ultrasound can show tract-like sonolucency through the testicle, as seen over here on the left, this black lucency there, given the bullet tracking through the parenchyma. It can also present as heterogeneity within the parenchyma, or a loss of the oval shape, seen on the right-hand side. In terms of review of gunshot wounds to the scrotum, Simhan had the largest study. They had 97 patients with penetrating scrotal injury. And all these patients were treated with the standard ATLS guidelines. What they found was that of their 97 patients, 94 of these patients underwent operative exploration. Of these patients, about 50% of them required orchiectomy. Of the patients that had testicular injury, about 7% of them were bilateral in nature. They concluded that scrotal injury was associated with high rate of injury to the testicles. The operation in terms of exploration was minimal in terms of its morbidity, and so this supports the current guidelines for exploration as the go-to for penetrating injuries to the scrotum. You have to also have a high index of suspicion for concurrent injuries to surrounding organs. So in terms of the treatment of testicular injury, exploration, on the bottom left you see hematoma being evacuated. In the middle, the testicle is reapproximated and the tunica albuginea is reconstructed with absorbable suture. And unfortunately, on the right-hand side, this is a patient that didn't have any tissue that was suitable for reconstruction. The technique has been described both as midline or bilateral. Irrigation and debridement are necessary. Drain placement is optional. As I mentioned, orchiectomy rate is pretty high, ranging anywhere from 25 to 65%. Antibiotics are required. And sperm extraction could be something to be considered at time of operation. In summary of the current literature, Simhan presented this table in their paper. Most of the studies were small in nature, except for the 2 that I've placed arrows next to. They had 62 and 97 patients, respectively, and both of these studies had approximately a 50% orchiectomy rate. So in regards to reconstruction, there are times when there's viable parenchyma, but you don't have enough tunica to reconstruct the testicle. And what do you do then? Well, there's options to use PTFE graft or tunica albuginea, which we have a lot of experience using as urologists. Ferguson and Brands looked at the difference between PTFE and tunica vaginalis as graft material. Although they only had 2 patients with PTFE, both of these patients developed graft infections and subsequently had to have orchiectomies. They concluded from this that PTFE is not ideal due to its foreign nature, not conducive to use of antibiotics, and resistant to the host defenses clearing out the infection. They therefore recommend tunica vaginalis as an option for reconstruction when there's inadequate tunica albuginea for reapproximation. Another outcome of scrotal trauma is the fertility, and there isn't great data on this either, but Lin and their group looked at 10 patients with previous testicular trauma and contacted them anywhere from 5 to 48 months post-trauma. 3 of their patients underwent testicular repair, and 7 of their patients underwent orchiectomy at the time of exploration. You can see that it's not ideal. The mean age is different between the groups. One, with the testicular repair, the patients were younger by approximately 10 years, but they found that semen analysis in those patients that had orchiectomy were decreased in quality compared to control. This was also seen in terms of their endocrine profiles, noted to be elevated FSH and LH levels. So they conclude that testicular salvage is overall more protective of testicular function. So in conclusion, ballistics of weapons are important in terms of the assessment of GU injuries. You don't want to miss any associated injuries. You want to consider other scenarios such as fragmentation, secondary tracts in terms of gunshot wounds. Isolated injuries may occur but are less likely. The workup of the urethral injury should include a retrograde urethrogram. And overall, the penetrating injuries are managed with open surgical exploration, with the exception of those patients who are in dire circumstances, those who are hemodynamically unstable and can't tolerate exploration. Obviously, it doesn't help doing a scrotal operation if your patient's bleeding out from their aorta. The outcomes from penile, urethral, and scrotal injuries have been overall fairly good. Stricture rate approximately 15%, erectile dysfunction in the 15 to 25% range, and orchiectomy rates approximately 50%. Any questions?